only become all the more important as we go forward. Why? First, there are more and more complex health needs that are reaching the health system. 20 years ago, and look at the Millennium Development Goals, we were only talking about maternal and newborn health and perhaps infectious disease. Today, on this slide, I show some of the disease targets that are in the Sustainable Development Goals, just illustrating that we are all in a similar situation the world over, where we are tackling simultaneously malnutrition and overweight, right? Non-communicable diseases and deaths of newborns and children. Mental health that is absolutely crucial and underattended. So health systems are going to have to bear a greater set of expectations. And speaking of expectations, people's expectations are rising as well. Everyone has a cell phone, especially in India. I believe you have 1 or 2 per person at this point. That means that everyone's connected. People are on social media, they're on WhatsApp. They're understanding that even though they're living in a village, the cousin in the city may be getting better care. And so the expectations are rising everywhere. Finally, because we have had successes in reducing mortality, we now have lower levels of mortality. And epidemiologically, that is just harder to deal with. The next tranche of improvement is going to be more challenging. And so in the commission, we came up with a simple definition of a high quality health system. What is that system? Well, first of all, we want to remind everyone that health systems are for people. They are not for bureaucrats, policymakers, or doctors. They're fundamentally for and about people. And a high quality health system optimizes health in any one context by doing 3 things. Consistently delivering care that improves or maintains health. That's the first task. Being valued and trusted by all people, and responding to changing population needs. I think COVID has taught us the critical importance of being able to respond quickly to a health crisis. The Commission also came up with this framework for thinking about health systems. Those of you who are students of health systems know there are a lot of frameworks. In our framework, we really wanted to put a spotlight on what happens when people reach healthcare, not what is healthcare composed of, things like workers and tools and platforms and equipment. Those are things we love to count. What we wanted to talk about in the commission is what happens when those things all come together. What happens when your grandmother is ill and comes into care? What happens when your child is not growing and comes into the clinic? And so this framework focuses on processes of care and quality impacts. Competent care, positive user experience are key process measures, and quality impacts such as better health, confidence, and economic benefits are the impacts, the outcomes that we want out of good health systems. The Commission also identified 2 major research and development gaps. We should be thinking about healthcare as an industry, an important one, of course, for every country. And every industry needs R&D. We feel that measurement is quite behind in the health system. And improvement strategies are also off track. And let me explain a little bit more about that. I'm going to actually jump straight to improvement because I think that's what the majority of you are probably most interested in this conference. And so the key improvement recommendation from the Commission is that improving systems at scale will require working beyond one clinic at a time. It will require political and structural change. By contrast, most quality improvement in the health system globally is at the micro level. What do I mean by the micro level? Well, it's working with the health worker, trying to remind them to do better, working at the facility level, perhaps equipping that facility a little bit better, maybe asking the user to demand more. But that's just one level of the health system. We can step back and look at other levels that are equally important at the meso and macro level. So does micro level solution work? I want to share with you results of a study in which we assessed training and supervision, 2 very popular micro-level solutions where we're supervising health workers and training health workers with short courses. And what we see is there is no influence of those trainings and supervisions on antenatal care quality and minimal improvement in sick child care quality 2 years later. And so this is not the case that we are making huge progress on quality by using micro-level approaches. And I should point out, these are not easy to do. Many of you have been doing training and supervision. You know you have to do this one clinic at a time. It's difficult to do and difficult to scale. So we need to move from the local to the structural, from the facility to the system, from behavior change to foundation change, from short to long term. And of course, the opportunity there is to shift our thinking from local scale, from 1 clinic or 15 clinics, to a large scale change. So why is it so important to do this in the health system? Why doesn't it work to improve 1 clinic at a time? And that's because improving a health system requires addressing the fact that it's a complex adaptive system, and it's not remotely the same as fixing a heater, or simply one part being exchanged will make that heater work. Systems are complex with interconnected parts, and they're adaptive. They're able to change based on experience. We also know, and I think you know this very well in India, that their health systems are emergent, governed by feedback and history, and extremely context dependent. Politics really matters. The history of your state really matters, and where the health system is today. And some of the ways in which improvement goes wrong is in thinking that very mechanistically, that simply adding more inputs will automatically mean better quality. You know, putting more soap in the facilities, which, by the way, I'm very for soap, but the soap itself will not wash the hands of the health workers, and the health workers will not automatically do a better job for the children. Those things do not follow linearly. What we also know is that complex adaptive systems need simple rules. Rather than being micromanaged, you need simple rules that point the way to success. And so direction pointing is one of those simple rules. Do we have agreement in every state on the nutrition goals and how we're going to get there? Do we have limits and prohibitions that limit practice that is actually not helpful but potentially harmful? I think sometimes in health systems, we're all about resources and incentives and don't think enough about the limits as well of care. And finally, of course, we do need resources and incentives to align the health workers, the ASHAs, all the participants, the parents, in the direction of better outcomes. And so in the commission, we spoke about 4 structural reforms, and I'm very keen to hear from you all how these might apply to nutrition. So these are structural or macro level reforms that help us improve health systems. The first one is governing for quality, thinking very much about how do you organize, manage, and govern a health system all the way from the top, from the PS level perhaps in India, all the way to how facilities are led. Second is modernizing pre-service education. We have got to stop thinking that 1-week courses are going to fix all the problems of our health workers who are graduating without the requisite skills and knowledge to do the job. Instead, pre-service education needs reforms. Many of the systems that are out there today have not been reformed since the 1960s in many cases. Redesign service delivery, and I'll talk about that one in a moment. And finally, igniting demand. We need to enlist the population to push on the health system to do a better job, and of course to take better care of their own health. So let me come back to redesigning service delivery, because we think this is a tremendous opportunity, and one I've been very encouraged to see you're already pursuing in important ways in nutrition in India. When we talk about redesigning health systems, redesigning service delivery, it's all about how do we reorganize services, workers, and actions in the health system to maximize survival. Let me repeat that. To maximize survival, not to minimize distance to care, right? Not to maximize contacts with the health system, but to maximize survival. So on this slide, I'm giving an example of newborn survival. Newborns, too many newborns in India, in many parts of the world, are born in primary care clinics right here, primary health centers, that really aren't able to respond to that newborn's crisis, should there be one, at the time of birth, or the mother's complication. And instead, we're hoping and keeping our fingers crossed that there may be transport or there may be referral. The reality is those don't work. Instead, deliveries, which are a service in a condition that require rapid expertise if a complication arises, should be probably located at the secondary or hospital level. Whereas primary care workers can do much more for newborns after delivery. And so I was struck by the materials that you shared with me about how actually you have been very clever about accessing other platforms in India to reach nutrition goals. You've got the health system in here, the formal clinics, you've got ASHAs, you've got the ICDS program that I've learned about, you're using schools and preschools, right? And you're reaching directly to mothers as well with information and communication. And so it's already, you're exhibiting a tremendous amount of, I would say, innovation in thinking about nutrition as a multi-sectoral, multi-platform set of services. But your conference is also about implementation science and how do we use implementation science to improve systems. I'm sharing with you one framework that I find helpful, the EPIS framework, but there are many implementation science frameworks that reminds us that, that improvement is a stepwise process that requires careful consideration of outer context, inner context, bridging, and innovation factors. It isn't, these interventions are not going to implement themselves. It really will take a system and careful systematic analysis. All right, so just thinking about two aspects of implementation science that I think are absolutely crucial to the structural changes that I'm calling for. One is understanding the outer context of our settings. So in India, this may be the state and the national context, economy, the policy, the political economy. Where is there space to maneuver in any one state to maybe adjust pre-service education or adjust service delivery? What is the view of users? How active are they? Who are the funders? I know that in India, for nutrition, you're working between two ministries of health at the national level with their own cultures, their own goals, their own staffs. And it's, again, I'd be very curious to hear how you've managed that, but it seems to me that it's widely understood that they're influential and critical to engage. COVID-19 is another example of the outer context, right? How do we manage at a time of crisis? A health system is not just for one thing. A resilient health system needs to be able to care for COVID and needs to be able to care for the routine conditions in front of it every day. Life does not stop because we have a pandemic. Inner context, we need to understand the specifics of the health system. I understand Kerala is very different from UP and similarly the other states. Every system has its own particular way of organization and leadership. And again, you have been able to work across two sets of programs, the National Health Mission and the Integrated Child Development Services to deliver for children. And I think the question that I would ask is, what is the level of integration between those to be able to permit the outcomes we want? Just in wrapping up, I want to come back to this perhaps disappointing point for everyone, which is that there are no quick fixes to building the high quality health systems that we want. Here on this slide, I've assembled just some of the building blocks of high quality health systems that have been achieved and are still being tweaked and worked on and every day reformed in high income countries, high performing health systems. This is just a short list, and it's definitely not comprehensive, of all of the things that are in place to make a hospital work, to make a clinic work. Quality standards, supervised practice, effective regulation, rigorous training, extremely tight selection into training. Once people are trained, management and resources. We have a huge malpractice industry that has problems, but at the same time is used to redress some of the issues that go on that are not acceptable. And then finally, it's about QI maybe and incentives. I just want to point out, that's a tiny sliver of the whole pie. We need the entirety of the foundations to work in order to have a high quality outcome. Oh, and I did not focus on a really important point, which is that ultimately the decision to have high quality health systems is not a technical choice, but it's a political choice. And so how do we use implementation science to improve systems? Well, we need to address the evidence gaps in measurement. We've got to stop counting things in cupboards and instead look at the way that people are treated in clinics and whether mothers, when they exit with that undernourished child, really understand what's going on. Do they really know what to do when they get home? Because health will be created at home much more than in clinic. We need to de-emphasize the point of care quality improvement. We need to think about what do we do at the structural level. We need to improve our measures and make them faster and more nimble and more accurate. We also need to be thinking about the future. I think sometimes in health systems, we're solving for problems of yesterday, when in fact we need to be thinking about problems of tomorrow. We had a brief chat with Dr. Ved just ahead of this, thinking about how the ASHA program, for example, is evolving to face tomorrow. When more and more people are educated, will they be coming to ASHAs? Will they be expecting the same services, or will they be looking for something different? And countries do need to learn from each other to avoid expensive failures, and this is where science can come in. In India, I would say states need to learn from each other to avoid expensive failures. And what I think of as replication of failure, which is all too common. When we take a great sounding idea and for many years it persists despite having been a failure in one or two settings. And so finally, I'll end by calling for rigor, scientific rigor in implementation science, not anecdotes, but really rigor, but combined with local relevance and local interest in these results, because both of these are critical for impact. And the impact is healthier children. I think that's one thing we can all agree on. So thank you so much for having me. And I'm really looking forward to the discussion.
Wonderful. Thank you, Margaret, for being super on time as well. There were way too many quotable quotes in your talk for me to keep track of things. But one thing you said resonated so much with a discussion we were having earlier today on infant and young child feeding behaviors, which is that health is made at home. Babies are fed at home 5 times a day times, the first 2 years of life. And there's really only so much that clinics can, or centers or anything can do to support families to do that. Let me, without further ado, I call on Alok to offer his reflections on your remarks. Alok has told me that he'll reference his experiences primarily at Niti Aayog, but I'm sure you have other things to reference as well, Alok. So over to you. You have, about 7-8 minutes, if that's all right. And then we'll come to Rajani after that. Please, everyone else, add your questions and comments in the Q&A box. We'll keep an eye there.
Thank you, Purnima. Dr. Margaret, Kruk, Rajani, Dr. Rajani Bed, others on the panel, and the audience. Thanks for having me here. It was great to hear I think I could not agree more with Margaret that health system, building quality health systems is a time-consuming process, and time is something which nobody has. Everybody is impatient, and that leads to a lot of quick fix interventions, which are all improvement. Directionally, we are going right, but maybe we are not getting enough, as they call it, bang for the buck, which means that maybe there is a potential to do better than what we are already doing. What I wanted to concentrate more on is, because the topic is really nutrition outcomes, and what are those interventions that we saw created major changes, and those were really the 1,000-day window, which much celebrated 1,000-day window, which was emphasized, and now it is almost a universal consensus. Everybody agrees that particularly for nutrition outcome of the children, we need to really look at those interventions in a very serious way. And what I wanted to do was to separate the interventions at the facility level from that at the community level and also at the household level. So I think there are 3 levels of intervention, just as we have 3 levels of interventions at the facility level, primary, secondary, and specialty care. Similarly, we have 3 levels of interventions. One is at the household level, one is at the community level, and then we have some residual requirements at the facility level. Now, in that, we in the aspirational districts, which were identified on the basis of their educational, nutritional, and health backwardness, what we found was that a large number of interventions which would ordinarily happen or should ordinarily happen is not happening. For instance, I was just looking at these figures from India. Almost 80% of the births are taking place in the facility. And yet, if you look at the percentage of children whose breastfeeding is initiated within 1 hour of birth, it is only 25.2% in UP and 41% across India. Now that, to my mind, is an intervention which is crying to be implemented, because all it needs is getting an SOP in place, and that is, I think, the idea of quality what Margaret was referring to. And similarly, if you look at whether people go for ANC checkups, at the ANC checkups, what is the quality of that level of checkup? So are we just ticking the boxes, or are we really doing a good job in terms of identifying high-risk pregnancies, identifying mothers with poor, low birth or low BMIs, early age pregnancies, or those who are likely to have iron deficiencies, anemia, severe anemia. And one found that if you look at the field level, what is happening was that while we are trying to do, and I think in that sense, NHM has been, and also now the nutrition mission has been a real game changer in terms of increasing awareness about these interventions. But the implementation of those interventions remains patchy, and in some places they are implemented well, in other places they are not implemented well. And that, I think, is a great area for intervention, and one which I think will give a lot of improvements in outcome at relatively moderate levels of effort. The second point which I wanted to make was with respect to community involvement or the demand side. I think Margaret alluded to it. That, I think, remains a big area of intervention, because I think governments are usually good at, I don't know, maybe they are not very good at even doing the supply side interventions, but relatively better at doing supply side interventions than looking at demand side interventions. How do you involve communities? There are no quick fixes to that, and particularly where certain traditions are deeply ingrained in that community, it is very difficult to change behaviors of people. For instance, there was this district, Lalitpur in UP, which had very low levels of early initiation of breastfeeding, because there was some belief in the community which said that the first milk should actually be offered to the gods. And that, but it took 3 years of concentrated effort by UNICEF and a set of people who counseled people and emphasized the importance of colostrum, and that district now ranks, has 71% early initiation of breastfeeding, even higher than districts in Kerala, which is not an ordinary feat for a district in UP to achieve. So how do you work with communities? And the challenge is also that many of the frontline workers come from the same communities, sharing the same belief systems of the communities. So it's almost like a mutually reinforcing set of behavioral patterns. And at a higher level, the challenge is how do you break this cycle? And that seems to be another area which I thought was something that could be done. And in our experience in the aspirational districts, we found that if you target a certain number of interventions, limited number of interventions in a very, very intensive way, then you are likely to change. But the unfortunate thing is, what happens is that because everybody seems to think that their program is important, the poor worker is saddled with 1,000 priorities at the same time. And that becomes difficult for her to cope up with. So the question of prioritization also becomes very important. And lastly, without community involvement, I think no country in the world that I am aware of, the battle against malnutrition has been won without involvement of community. For whatever reasons, this slow withering away of the child, this stunted child or the wasted child still people do tend to notice, but the stunted child is almost imperceptible, and in the eyes of the community, if almost every other child or every second child is stunted, then you don't feel that there is anything abnormal with that. So how do you get community involved? How do you raise community awareness is a matter more of behavioral science and implementation of that aspect of change management, which the ordinarily facility-based care is completely oblivious to, or largely oblivious to. So I think I would make only these 2 points at this point in time. I see that my time is almost out. So maybe during, if there is time for interaction, maybe I can put in a few more thoughts.
Great. Thank you, Alok. I like that you brought the community in, and it's a great segue to the comments that I know Rajani will offer as someone who's been supporting and sort of engaging this large community health workforce to support not just health, but also to sneak in at least a little bit of nutrition in there. So Rajani, over to you for your remarks, and I can see that we have a few questions coming in after that. So we'll come back here then.
Thank you very much, Purnima, and it's been great being here and listening to Margaret and Alok. So yes, certainly the ASHA, and I'm a little bit disappointed to hear you say a little bit of work in nutrition. To our mind, in fact, the 3 roles of the ASHA that are always articulated, the facilitator, the activist, the community level care provider, really come together most of all in nutrition. Remember that she does work from home-based newborn care to home-based young child care way before the child even reaches the Anganwadi center. And it's really in the ASHA's remit to be able to counsel the mother on both exclusive breastfeeding, on supplementary nutrition, on complementary nutrition, on initiation of weaning. So she has played a very important role. And I'd like to, certain things that Margaret said really resonate with us. Certainly the reorganization of service delivery, which we are seeing happening in a huge way in the primary healthcare initiative and the reform, where the ASHA is moving to slowly becoming a part of the primary healthcare team at the sub-health center. So redesigning service delivery by shifting chronic care management more towards the community and the sub-center level and moving other interventions higher makes sense. The point about training and supervision, Margaret, that you made about training and supervision in some of your studies showed that they had little impact on quality. We're seeing that in the ASHA program as well. ASHAs are trained. They have quite an extensive and systematic training program, and we do have a dedicated support structure for the ASHA. But our feeling is that unless it's accompanied by the tools and equipment that she needs to conduct her work regularly, balanced with intensive community participation, which unfortunately hasn't taken off as well through the village health sanitation nutrition committees, which were intended to do just that, to be the community collective to root the ASHA. And that perhaps is why the training and supervision sometimes feels as if it hasn't worked. That's in our context, and I'm sure in the other context it may work to be true. For me, the quality issue really is the quality of convergence. I think we've seen, the ASHA moved from being an individual worker. Sure, we had very good role clarity in the beginning between the ASHA and the Anganwadi worker, but I think, and the ANM, the AAA platform as they refer to, work very well in many areas. But I still think there is potential to look at what really helps convergence. Is it an alignment of incentives? Is it the fact that there is a little bit of a power hierarchy between all 3 workers that limits the effectiveness of convergence? Is there not a sharing of goals or information? So certainly one thing we've noticed is that when when children above 3 are weighed in the Anganwadi center, the information doesn't automatically go to the ASHA. And therefore the ASHA is not able to work with families with whom she's a much more direct visitor than the Anganwadi worker to look at issues like growth faltering. So it's not till the child is really visibly ill and has to go to an NRC that the ASHA is actually referring. So I think there's something there that we can do and improve the quality of early identification of growth faltering, at least by some sharing of information. So for me, the studies and research on the quality of convergence is very important. We've talked a lot, and Purnima and I have also written papers on intersectoral convergence between health and nutrition, and I agree with her. The health system has equally, if not more, to do with nutrition than does ICDS, particularly 0 to 3, where the ASHAs are making home visits. And I think just like Alok brought up the point about low breastfeeding and high rates of institutional delivery, and it's a question that needs to be looked at. Would just an SOP do? We know from the Better Birth checklist that the studies that went on in UP, it was not sufficient in changing behaviors. While the intervention was on for 1.5 to 2 years, the ANMs did what they were supposed to do, but the minute the researchers left, everything went back to the way it was before. So how do we make these changes happen? Because they really are important for the quality of care that's provided, whether in facilities or in the community. And I also think counseling, everybody expects the skill of counseling to be sort of inherent within the ASHA. But remember, she just has to navigate so many social relationships and hierarchies. And as Alok said, she comes from that same community. Sure, there are barriers of caste that she has to navigate, but she is from that community. And for her to be able to convince, she needs a special set of skills. And once she's able to overcome that, you see that in Jharkhand, in Orissa, in Chhattisgarh, where there have been really impressive changes in nutrition, has happened because there has been sustained work on the ASHA as a focus to deliver nutrition in the community. Of course, there's been work with the Anganwadi and the ICDS system as well. So I think the changes that we are not seeing at grassroots level for nutrition is because because of the poor quality of whether it's counseling, and I'm not even referring to the food part of it. I'm referring to the community level interventions and the nature of support that's provided to all three workers. The ASHA has a dedicated support system, and that focuses on, because the ASHA has a role of multiple other functions as well. It's not just nutrition. So the ASHA gets the support system, but this AAA platform that we all seem to hinge on is not really getting the kind of support and supervision that it deserves in order for all three workers to function together to improve the quality of nutrition services. I think there was one more. The other area where is performance measurement. I think in the ASHA program, we've not done such a good job of performance measurement, let alone measurement of the quality of services that she's providing. And I think that's an area that needs to be worked on. And for this, I think digital tools will be critical. And I don't know how much of that is being used in the Anganwadi system, but I think for the ASHA now, with primary healthcare reform coming in, all ASHAs will have smartphones and they will be assessed, and there will be a way of assessing them. But having digital tools and technologies to measure performance and then balance it out with appropriate training, supportive supervision, etc., is really important. So I think I'll leave this here, Purnima, and ask and respond if there are any questions, either from the other panelists or from the audience.
Yeah, great. Thank you. Thank you, Rajani, to both you and Alok. Very sort of thoughtful and also, I think, most importantly, very grounded perspectives coming from a system that both of you have had deep experiences in. I have one question for, I think, all three of you to think about that maybe we can come back to later. So I'll just put that out there, and then I think we do have a couple of questions in the Q&A box, and I'm really encouraging everyone to please add your questions into the Q&A box. So my question to all three of you is around the issue of culture. It's around the issue of culture in systems. I think at some level, all of you touched on that in your remarks. And we've been hearing about it in the context of, we've been talking about it in the context of data use as well. But I think there's a much deeper, there could be deeper issues related to quality, quality and nutrition as part of that relate to the culture within systems. And I'm wondering if you can just reflect on that and share some thoughts or experiences or insights on that. And then I think another question for both Alok and for Rajani is, what are some big questions that relate to nutrition in the health systems that you have, that the researchers in the room, there are several researchers in the audience as well, could sort of come in on, because one of the big things we've talked about throughout the day is about implementation research being relevant to context. And I realize, Margaret, that a lot of what you talked about was issues that cut across context, but I wonder if in the context of some of those global questions, where is nutrition fitting? But those are my questions, and I know I have a chance to to reach all of you as well. So let me ask a few questions here that have come in from the audience, and you can decide who responds to that. Shruti Shukla has a question that's that says, we've thought well about converging various ministries for improving nutrition outcomes, but are we missing out on addressing some of the sort of very basic underlying issues or root causes? She talks about family, I'm going to say family planning, Shruti, rather than population control, and I hope that's okay. Sort of addressing these issues such as family planning that intersect. The second question also relates a little bit to, I think, the issue of convergence, but it relates to the, Alok, your perspective, if you will, on double fortified salt in the context of the PDS. That isn't really, very much related to health systems, but certainly health systems could promote that. The issue of political will, I think that's another big elephant in the room. How do you create political will, or how can we bring that? Nutrition is in an interesting space right now in India from that perspective. Very visible political signals across the system, and it would be interesting to hear all of you reflect on that. And then there are questions, I think this may be from Dr. Sheila Veer, I don't know, it says Veer, about technology, but that's a range of questions that are all visible to you as well. So let me ask you one by one, maybe Margaret first, and then Alok and Rajani in that order. Please take any of these questions that you'd like. We have another 10, 12 minutes in the session, so thanks.
Well, thank you, Purnima. And I think most of the questions will be most appropriate for Alok and Rajani to weigh in on. But I am struck by the fact that nutrition is a really challenging topic because of the multifactorial nature of it, and that in order to tackle it, you really do need to address determinants all along that pyramid that I showed. And I think that's a humbling moment for the health system. I think sometimes we do try to say, healthcare is really the answer to all of this. It has to be part of the answer for sure. But as Alok said, figuring out how the health system can engage communities in a meaningful way to get the outcomes that we all want is part of the equation. So it's not just a technical set of questions for the health system. For example, what are the best supplements, or how do we measure growth in the most in the best way? Although I think those are still critical technical questions. But in a way, I think nutrition puts in front of the health system one of the more nuanced and more challenging question, one that I think will relate to many other issues that are socially determined in very large ways. And one of those elements of that question is, how do we work with users? How do we develop a relationship and confidence in the system such that the mother will get her needs met, and it's usually the mother, will get her needs met, will come out with a sense of empowerment and knowledge when she leaves that clinic. And for systems to achieve that is a bit of a different question than simply how do you get this vitamin into this child during the visit. So it requires a greater intelligence in a way on the part of the health system to figure out how to work on these more complex issues. And I think this then brings us back to the question of political will, leadership, and governance. That as we are thinking about who runs the clinics, who runs our systems, these also have to be people who take this into account, who understand how to manage and motivate individuals, right? The health workers, but also making sure that the health workers can motivate the mothers. And again, linking to your question around culture too, those leaders are the people who set culture. They set the tone of the organization. And to the extent that we have well-motivated, and I would say specialist trained leaders in health systems, that would be very important. I think all too often we rely on doctors to run clinics or systems, and doctors have many wonderful talents, but management is not always one of them. I'm a physician, so I feel I can say this. And I think, you know, thinking about instilling more and better trained managers and leaders throughout the health system will help us think about the role of the system differently and take it out of the narrow, very narrow technical sphere that it's in often.
Thank you. Rajani or Alok, who would like to go next? Alok, maybe you can go, and then Rajani and I can help wrap up the session.
I was just trying to say I will gladly cede the floor to Rajani first, and then I can go. Or if you want me to, I can. I mean, either
go ahead. You're speaking.
Go ahead. Rajani has much greater insights than me, so let
I don't know about that, but I just wanted to address the specific issue of culture of quality. And I've been thinking about it quite a lot, particularly from the point of view of program managers and practitioners at the district level. I think we have this long-standing legacy of worrying about coverage. You know, so it's always been 90% coverage for everything. So I think quality sort of takes a backseat. And that legacy is still with us because we haven't yet gotten to coverage, much less, and certainly not thinking about effective coverage. And I think partly it touches upon what Alok said. We hardly give ourselves time to make sure that a design is actually implemented properly before we add 3 more components to it. So this layering of components, multi-components, competing priorities, and an underfunded system, both financially and with human resources. Also, I think partly we don't have the ability to do good multitasking and task shifting. I think that's an area in which we need to go for us to be able to say, how can you handle, so all the priorities are important. NCD is important, as is nutrition, as is communicable diseases. But I think a little bit of that, not all of it, can be addressed through multitasking and task shifting. And I don't think we've done that very well, simply because we also have these strong power hierarchies in place. What can a nurse do? What can a doctor do? And therefore we are stuck in that loop a little bit. And then I also think we don't make enough opportunities to reflect, to share, to learn. There are not incentives enough to do that, and which helps actually in people doing, because quality needs all of that. I mean, it goes beyond this actual coverage and reaching more people. It's this opportunity to be, and to have incentives to do that, whether it's training programs, whether it's getting financial incentives if you get outcomes. But I think we don't do it. And maybe these are all areas for implementation research, is to see how you can introduce them into some systems and see how systems function, you know, I mean, and actually make it part of the system. And that's why this culture of quality is a little bit elusive as far as we are concerned. So that would be my, and I think there was one more about technology for accountability. I wouldn't want to put accountability right on the frontline workers' doorstep. I think everybody has to be accountable, giving, you know, making sure there's talk of putting a chip inside the ASHA, which I kind of detest. Yes, of course. That's the kind of conversations we've heard, to know where she is at any time. She's only a volunteer, for heaven's sake. We have full-time workers who are never there in their places. But yes, technology as a way to measure performance, to support, to incentivize, these are all important things. And I think technology does have a role there. So I'll stop there and let Alok.
Great. Alok, I'm wondering if you can speak to the question of political will and leadership, and then also, you know, in the work that you've seen, what are some big questions that the research community can also pay attention to?
I will start with the convergence part. I think that is something which is kind of an elusive goal. Until as long there will be bureaucracies, I don't think there will ever be a, you know, despite whatever you write on the paper, there will ever be the kind of convergence that we talked about. When we are the 2 departments who are servicing the same mother and the same child, they can't agree on a common list of beneficiaries, then the idea that they will all collaborate towards some specific goals and outcomes seems to be, to me, a little bit, you know, far-fetched in some senses. Although I think the national nutrition strategy that I had the, you know, in some senses privilege to influence and author, played a lot of emphasis on convergence, and some of it at least if you give them a platform, for instance, you gave them a platform of village health, sanitation, nutrition days, and you find that in a structural way, there is some level of collaboration between the ICDS system and the health system in that. But till as long as you have separate databases, you have separate reporting formats, you find it very difficult for people to achieve convergence. So in some senses, I think while I agree with Rajani that the accountability cannot be laid on the door of the frontline worker, it's only, but I think a large part of the elusiveness of the quality element is because we measure numbers in terms of numbers of families reached. So coverage is easier to measure than quality. And I think Margaret has put in her life behind this whole idea of measuring quality. And it's not a very easy thing to get. And I think because it is not easy, and because it is easier to then layer more programs and to come up with the most glamorous ideas, it is easier for policymakers to layer more and more programs rather than really looking at how to improve the existing programs in a way that it gives better outcomes. So I think that is a fundamental question, because from a political perspective, I see it is easier, and even from a bureaucratic perspective, I see it is much more glamorous for people to announce new programs and to lend their names to it. And in some senses, I have been guilty of that also. But it is a far more difficult and below the surface, below the radar work of actually thinking about every element, what goes into delivering quality, measuring those qualities, and improving it in a secular way without really making the workers responsible for it, but gradually putting everybody's thought processes together that, look, this is how we need to deliver this service. And unless we get it right, the amount of investment that we are making in terms of both financial resources and human resources and their time is not well served. And that again then brings back to the political question, is what interests the political executive? What is it that wins them votes? Is it really creating new programs with mega announcements? Is it really creating more facilities, more equipments? Or is it those small micro processes that lead to priority? And I think the answer is quite clear, and till such time as you have the demand side really looking for that element, politicians in a democracy will respond to what the demands are. And therefore they come up with more facilities, brighter, more equipments, more high-tech things, gadgetries, and then you have these, administrative control freaks who would want every data, every single point to be available at the click of a button. Researchers also, in some senses, do like these, billions of data points where they can do all these snazzy, what we call as the big data analysis and come up with all kinds of insights. But they don't help the people on the ground because they want the services to be delivered in the right way. And I think it's hard job, but I think we need more champions like Margaret to kind of emphasize this element of quality, that there is almost a trade-off, I would say, between the quantity and the quality. And I think there is a case for, and I've been quite vocal about this, of freezing new programs and trying to do better with the existing programs. And I think that is something which I have been very unsuccessful in doing that, but I think there is something of a prioritization which needs to be done. But so far I have not been able to, really to influence my colleagues in any significant way on that.
All right, so I see both optimism and pessimism, Alok, in everything you said there. we're a little bit over time. So I just wanted to check, maybe Margaret, Alok and Rajani, if you can stay another few minutes so we can wrap this up. I'm seeing some nods there. Yeah, Rajani, can we say 10 minutes more?
I actually have something else, another webinar at 6:30.
All right,
started,
okay.
I guess. Sorry.
It's 6:30. So then let's try and wrap this up. So,
sorry about that. Sorry.
No, that's completely fine. I thought this was a phenomenally rich discussion, and when we, planned this, our team went back and forth a lot on whether we should try and get a 75 or 90-minute session instead of 60 minutes. And I know now that we made a mistake in not getting a 75-minute schedule. But let me then just try to wrap us up and close this out. So Rajani, you can leave. Firstly, thank you so much, Margaret, Rajani, and Alok for joining us. And Rajani, I think I didn't know how open your nutrition agenda was, which is why I said it was light. So I'm just going to explain myself there. I know you worked hard to get nutrition into that platform, and the nutrition community is really grateful for, I think, what we've seen in India in the last 10 years is sort of real deepening of interest and an expansion of the kinds of work being done to address nutrition within the health system. And I think it's because we recognize that we can't meet health goals without walking together to also meet those nutrition goals. If more than 60% of deaths under 5 in India are attributable to malnutrition, the health system has to pay attention to that as well. But to all three of you, I want to thank you for your remarks. It sort of assures us that the folks who are thinking hard about health systems are also thinking about nutrition and appreciating, what it's going to take to deliver nutrition with quality at the same time in these health systems. I thought the discussion on all the things that relate to quality, all the way from the building blocks to the political will to really the demand side as well. How do we get people to ask for more from their own health systems? I think that's a question that we're all struggling with also. And so I hope that this is, in a sense, the beginning, not just of conversations, but the beginnings of some serious work that, I hope that we and others in the room can do together to strengthen both the integration of nutrition in health systems, but also the integration with quality and the overall health system delivery with quality as well. I think the experimentation must continue, the lesson learning must continue, but there's no turning back at this point in terms of the integration of nutrition with health systems. So again, thank you all so much. I know there've been folks tweeting and live tweeting and all of that stuff, but once we have the links actually up for these, we'll share that back with all of you. Any last words from any of you, Rajani, Alok, or Margaret? 30 seconds. No. All right. Okay, great. Well, thank you all so much, and thank you to everyone who joined. I think at some point we had over 100, and I don't know how many were viewing the live stream as well. Yeah, it was a wonderful session and a great kickoff to the first plenary of this 4-day conference. Thank you so much again.
Thank you, and bye everyone. Bye-bye.
Thank you.
Thanks.